Dr. Lloyd, thank you for joining us on MD Newsline podcast. Can you please introduce yourself to our audience?
Sure, thank you for having me. My name is Sherene. I'm a medical oncologist and a lab head at the Peter MacCallum Cancer Centre in Melbourne, Australia.
You've published a pretty interesting paper recently, I think by Five today. So that's very exciting. Can you talk to us a little bit about the paper? Maybe start by summarizing some of the key discoveries, such as how parity and breastfeeding appear to enhance T cell immunity.
Sure. Yes, the paper is out in Nature today. And basically, what it describes is a mechanism on how pregnancy and breastfeeding results in protection against breast cancer. Specifically, we're looking at triple negative breast cancer. For a long time, my lab has worked on the immune infiltration of specifically triple negative breast cancer. And now we know that triple negative breast cancer can be treated with immunotherapy really well. It improves survival outcomes in both early and late stage triple negative breast cancer. So this reinforced to us that the immune system is really important in the growth of triple negative breast cancer. But in our research, what we found was that in breast tissue, so cancer unaffected tissue, we actually saw a lot of T cells or immune cells in normal cancer unaffected breast tissue. And so we were wondering why you have immune cells in your breast when there's no cancer or infection normally. And so that made us look at the epidemiological data, and we know that having more children and breastfeeding is protective long-term against breast cancer. And we know that the global incidence of breast cancer is rising around the world, and a lot of it's thought to be related to reproductive issues. So we wondered if pregnancy and breastfeeding resulted in more immune cells in your breast, and that could protect against the development of triple negative breast cancer, and also maybe help with the growth or contain the growth of triple negative breast cancer. And that's what we're harnessing when we treat with immunotherapy and we treat patients with triple negative breast cancer. So that was the hypothesis, that pregnancy and breastfeeding increases your T cells, specifically in your normal breast. And so how we looked at that was, first of all, we looked to see if women had more T cells in their breast tissue if they had children compared to women who did not. So to do that, we looked at around 250 women who'd had breast reductions or prophylactic mastectomies, so normal, healthy breast tissue. And we looked at their immune cell content, and we found that yes, that women who had children had more T cells in their breast compared to women who did not. So then we went to a mouse model, several mouse models actually, to try and understand if this was the same as in mice. And we found that was the case in mice that had undergone pregnancy, babies, breastfeeding, and full involution, which meant that their mammary gland had returned back to the pre-pregnancy state. We found that their mammary tissue had more immune cells compared to mice that had not had any pups. So the next question was, is this important? Is this functionally relevant? So we implanted tumors into these mice and compared the Paris mice versus the virgin mice. And we found that, interestingly, the tumors, which are usually triple negative like in mice, were smaller in the mice that had undergone pups, lactation, and involution. So it seems that the immune microenvironment is modulating the growth of these tumor cells in mice. So next we asked the question, is this actually T cell mediated? And so what we did was, first of all, we looked at rag mice, and they don't have any immune cells, and we found that the tumors were the same size in these mice. And then what we did was we put back the T cells in these rag mice and compared mice that had, babies and breastfed and involuted compared to virgin mice. And we found that putting back just the T cells restored protection in those mice. So their tumors again became smaller. And then what we did was T cell depletions. And again, we found in those mice that we depleted the T cells, the Paris effect was lost. And so that's how we concluded that this protection is T cell mediated. And then finally, we went back to women patients to see if for those who developed breast cancer, because obviously it's not a guarantee you're not going to develop breast cancer, but if you do develop breast cancer and have had children and breastfed, does that change your whole immune composition of your breast cancer? And we found that, yes, indeed, that the breast cancers that had developed in women who had breastfed compared to women who had not breastfed had higher T cell content. And actually, they lived longer than women who had not breastfed. So we conclude that pregnancy and breastfeeding results in protection against breast cancer by changing your immune system, specifically in your breast, but also throughout your body as well. And so we think that this is the reason why women have protection against triple negative breast cancer long term. And even though there's been a lot of discussion about hormones in the past, about how estrogen and progesterone changes your breast. We think that's probably true as well for the hormone receptor breast cancers, but specifically for triple negative, it seems your immune system is really important.
Mm.
Sorry, that was a long time.
No, this is perfect. Tell me a little bit. So, when we talk about breast cancer specifically, there have been a lot of discussions about the impact of genetics, across different populations. And we know that some subsets of populations are more likely to have breast cancer spread or what have you. Did you see any differences across different subsets of populations of people with breasts, and did that
Yes.
impact?
Yes, so we did look at women who have high risk of developing breast cancer, so women that carry pathogenic BRCA1 and 2 mutations, but we found that actually it was the same finding in Paris women. So Paris women had more T cells compared to nulliparous. So the genetics per se doesn't seem to alter the effect of pregnancy and breastfeeding. Of course, that's really important for women who are at higher risk of breast cancer because it seems that the effect from Parity may be very protective for them as well in the long term. There are some populations, for example, African Americans are known to have a higher risk of triple negative breast cancer, for example, and perhaps do poorly. And there has been some talk because African Americans generally have more children and don't breastfeed. Maybe this is the reason why this observation has been seen. And we believe our data provides potentially a mechanism to support that.
Interesting. Do you envision potential preventative or immunotherapy strategies stemming from these findings, maybe perhaps mimicking immune reprogramming that occurs post-pregnancy?
Yeah, so basically what we think now that this is a paradigm shift in how we look at immunity. It now can become preventative as opposed to just for treatment. And an analogy to this is like the HPV vaccine, for example. We vaccinate to protect against HPV-related cancers. But yes, we can ultimately, now we understand the pathway, try to mimic that therapeutically with immunotherapies or vaccines, for example. Collect reproductive history because actually whilst doing our research we found that it's really hard to find data sets where people collect breastfeeding and parity history. So I think this is really important to understand the full effects of immunotherapy as we go forward. But yes, ultimately it's a different way of looking at prevention and how our immune system protects us against cancers and specifically breast cancer.
Yeah. And when I think about active immune systems or immune systems that are kind of acting maybe above the baseline, I think about so many different ailments. Like we just came back from multiple sclerosis conference and everything like that. Have you considered how some of this data might be used maybe at some point translationally to kind of gain this more full image of the body and maybe kind of signal potential other things? Do you see any of that in the future?
Yeah, I mean, I think there's no doubt that pregnancy and having children changes a woman's body, and there's a lot of evidence it also changes the immune system for good or for bad. It also has implications for cardiovascular health and diabetes as well, breastfeeding. So potentially there are related mechanisms of protection for other diseases and other cancer types. Obviously, that's speculation, but we do see that this immunity is not only just in the breast, but throughout the body. So it's plausible that this reshaping or new education of your immune system is protective for other diseases and other cancers as well.
Interesting. And, we talk a lot about things like technology at this conference and how we're setting up data for things like future use. This work is so exciting. I mean, the thought of maybe potential vaccine and preventative measures for cancer is exciting. What is the kind of the process, or what are you thinking about how data is being handled in light of emerging technologies, things like artificial intelligence and machine learning? Is that something that's on your radar right now?
Yeah, so the question is, what are these T cells recognizing if we want to develop a vaccine? Obviously, that's the $1 million question. And we hope that newer technologies will help us understand that because we're collecting the TCRs now and trying to understand what the T cell receptor is recognizing, of course, is very, very difficult. And hopefully these new technologies can help us with that.
Mhm. So tell me a little bit about what the next steps in your research would be. Are you looking at ways to pharmacologically or immunologically recreate this? What's your vision for the next kind of phase of your work?
Yeah, so we've spoken about vaccines, so trying to understand what the T cells are seeing. I think getting a better understanding of how reproductive history affects response to immunotherapies for the treatment of women with triple negative breast cancer. It is plausible from our data that we may be treating women who've not had children very differently from women who've had children, for example. Um, just trying to understand, for example, how um, therapies inhibit lymphocyte tracking, or how circulating of your white blood cells, because we can tell from our data it's really important that the T cells come into the breast as well as the ones within the breast to act against breast cancer, and you can imagine that would help for the rest of the body as well. And also, we can think about different screening methods for women who've not had children, for example. They might need more intensive screening or a different type of screening. We heard about these new blood-based early detection tests.
Mm.
So different screening methods as well. And obviously, there's the whole issue about supporting breastfeeding in our society. So, workplace policy, cultural supports, lactation support, and just support for women, because now we know that it's actually really important for not only the baby, but for the mother.
Mm. When we talk about these new treatments and even implementation of new technologies to get a better understanding of preventative care and treatment, I always think about cost and feasibility, in the real world settings. What are some of the opportunities and what are some of the areas for growth that you foresee when it comes to implementing this in clinical settings?
Well, I mean, the global burden of breast cancer is increasing, right? So if we can implement more, first of all, supportive breastfeeding, is potential that they might reduce the burden of breast cancer. And then finally, understanding how we can prevent it effectively will also reduce the burden of breast cancer. So ultimately, we get less women dying of breast cancer and less breast cancer per se. So I think there's a lot of interesting work to be done, leading from this research that could help women
Mm-hmm.
and give women more choices, actually.
Yeah, that idea of choice is really interesting from a maybe from like a financial perspective, because that's something that we talk about a lot, the financial burden of having, cancer and sometimes, being treated as a chronic illness. How do you have any view on maybe the affordability and how it might be implemented in less resourced areas or hospitals or countries?
Yeah, well, interestingly, I mean, this is not exactly my area, but obviously there's a lot of um, policy against, obviously, formula and marketing of formula in lower and middle income countries. But ultimately, I think, if we can effectively implement preventative strategies, we're going to reduce the burden and reduce costs for women. And it may be, taking off or supporting women earlier on in, child rearing and breastfeeding ultimately will be better off longer term for society, and developing new ways of screening and detection for women who choose to have children later or don't choose to have children will also reduce the burden of breast cancer for all of us.
When you think about the work that your colleagues are doing here at ESMO or even outside of this conference,
Yeah.
are there any studies that you're really excited about that you feel would pair really well with your work?
Yeah, well, I've spoken about the liquid tests for early detection. I think that's really interesting as well. So, new ways of detecting breast cancer, which are not a mammography, because I'm not sure you've ever had one, but yeah, it's not the most pleasant test. And also, mammography is only useful for older women as well, and we know the incidence is rising in younger women. So, new ways of screening women would be great. Um, and, from a therapy point of view, I think there are many exciting therapies that can be implemented now earlier, and that will result in more cure of breast cancer.
Fascinating. When you think about your fellow oncologists and immunologists, as they're listening to this, what should they take away about the intersection of reproductive biology and immune surveillance?
Well, this is a new field, so hopefully they'll take away that this needs to be looked into. But I think there is a lot of work around reproductive history and pregnancy and breastfeeding about the baby's health, but there's not a lot of work about the mother's health. And so hopefully we can look more into how that reshapes the immune system with regards specifically to protection against cancer.
Hmm. And in working on this study, was there anything that really surprised you that you weren't expecting? Because I know you had your hypothesis already, but was there anything that kind of was not on your radar that you found or that you're interested in exploring in the future that might not have been on your radar before?
Well, we were really surprised about how much it really affected the whole body. So, it wasn't just localized in the breast, the immune changes were systemic. So, that was surprising as well. And, from our point of view, it was actually quite surprising how much we couldn't find history of breastfeeding and the number of children women had had. Like it's poorly collected in data sets. And I think that's really just oncology as opposed to epidemiology. The epidemiologists collect all this history, but the oncologists don't. So that was quite hard to find. So we're really not going to be able to understand that fully, and particular responses to immunotherapies in trials unless we collect the data, which we don't do at the moment. So that was quite surprising as well, how little data is actually collected.
Yeah. Do you have any thoughts on why that hasn't kind of been in the forefront in the future? Is it just because kind of this hypothesis is so new, or is there a reason why it might have been deprioritized in the questioning process?
Yeah, I mean, it's a good question. People don't think it's relevant for when they, to their treatments of cancer, I guess.
Mhm.
People collect if you have children after your diagnosis of breast cancer, but they don't actually collect how many children you've had before and whether you breastfed leading up to your diagnosis of breast cancer. It seems from the studies we found is extremely rare. So I think that was actually it's a pity actually, but hopefully that will happen more now.
Mhm. And in presenting your work and kind of discussing these intersections, what are the most common questions that you often get from your colleagues on this
Yeah,
topic?
that's a
Yeah.
great question. So often I get, what are women going to say who haven't breastfed? Are you telling women now to breastfeed? And we're not telling women what to do. Basically, our work is about biology and understanding why you get the protective mechanism. And it's not about, choices or judgment or directives. It's just about biology and how we can improve things in the future. And we understand that breastfeeding and, having children is often an equity issue as opposed to, something that can be done easily. And also what we're describing is population level effects. So for the individual, it's actually the risk is very, very small if they don't breastfeed. But at a population level, the risk is big for the burden for society. So this is actually really population level effects as opposed to individual people's risk.
Mhm. Are there any questions that you wish that your colleagues were asking? Are there any conversations that you would prioritize? I've spoken to people about things like electronic medical records and intersections that they wish that people would kind of address more. Where are the gaps that you're seeing in conversation that's being currently had?
Well, yeah, that's a good question. I mean, I think generally, women of reproductive age have been poorly included in clinical trials in the past. It was really only recently in the last 20 years that actually women were included in clinical trials who were of reproductive age. So there's a lot we don't know about younger women in oncology. And certainly we don't collect enough of their previous reproductive history, as I've just mentioned as well. That's certainly not routine. In what we do. So I think now, hopefully, that's more systematic. And maybe we can capture it in emails. I doubt it because you have to actually ask the question. But yeah, I think in general, there's now a bigger focus on women and women's issues in oncology where they never used to be. Yeah.
Fascinating. Yeah, I'm really excited about this paper. Is there anything that you're looking forward to as far as technology goes? We've touched a little bit about on that already. Is there anything that we have not addressed as far as your research, your data, your process, or where you're going next?
Nope, I think we've covered everything.
Perfect. Well, thank you so much, Dr. Loy, for joining us
Thank
on
you.
MD Newsline podcast. It's been a pleasure.
Thank you for having me.